Femur, neck, fracture 3-1B. Stabilization using the Femoral Neck System, FNS. In this exercise, the procedure for the stabilization of femoral neck fractures will be demonstrated using the Femoral Neck System, or FNS, on the average femoral anatomy. The FNS plate used in this demonstration is a one-hole plate. Two-hole plates are optionally available. For below-average femur anatomy, the pre-collapsed insertion technique, shown in the final chapter, can be used. Upon completion of this exercise, you should be able to identify the clinical indications, describe the surgical approach, outline the steps of the operative procedure for insertion of the FNS, explain the optional intraoperative fracture compression technique, describe the optional pre-collapsed technique, and outline the steps of the operative procedure for removal of the FNS. The clinical indications are femoral neck fractures, AO classifications 3-1B1, 3-1B2, and 3-1B3. The clinical contraindications include per-, inter- and subtrochanteric fractures and cases where there is a high incidence of sepsis, malignant primary or metastatic tumors, material sensitivity, and compromised vascularity. In young patients, the preservation of the femoral head is essential. The clinical case shows a 62-year-old man who sustained an unstable Powell's 3 fracture, AO 3-1B2, through a high-energy trauma skiing accident. Shown are the postoperative and 3 months postoperative X-rays. The fracture is healed with minimal leg shortening and a minimal loss of femoral offset. The patient is positioned supine on a traction table with the non-affected leg flexed and abducted at the hip joint to allow the image intensifier access in the AP and lateral views during surgery. The anatomically true lateral view is achieved by rotating the image intensifier 10 to 15 degrees to correct for the anteversion of the femoral neck. Clinically, closed reduction is performed under regular image intensification in 2 planes. In a situation of suboptimal reduction, open reduction should be considered. Note that in this demonstration, the fixation of a stable valgus-impacted Garden type 1 fracture is performed in situ. However, in a case of a young patient, anatomical reduction should be considered. The lateral incision is based on the following anatomical landmarks: the femoral neck axis, the lateral border of the proximal femur, and the intersection line shown in green. The lateral stepped incision for implant insertion begins 1 cm proximal to the horizontal intersection line and extends 5 to 6 cm distally and slightly posterior to the central axis of the femur. The iliotibial tract and vastus lateralis muscle is split lengthwise. The split soft tissue is retracted, exposing the femur with the periosteum left intact. To maintain the reduction, K-wires must be inserted from the proximal area of the greater trochanter and directed either slightly ascending into the posterior or anterior part of the femoral head. Note that for demonstration purposes only, wires may be inserted through the femoral head in order to visualize their trajectories. The FNS instruments required for this exercise include the 130-degree angled guide, the guide wires, diameter 3.2 mm, length 400 mm, the correction guide, the direct measuring device, the reamer, consisting of the cannulated drill bit, diameter 10.2 mm, length 251 mm, the reamer component, the reamer nut, the insertion handle, the insert for insertion handle, the cylinder which is used for implant insertion and removal, the protection sleeve, which is used to both drill a hole and for the insertion of the 5.0 locking screw on the femur shaft, the drill bit, diameter 4.3 mm, the fixation sleeve, which, when assembled with the drill bit 4.3, is used to drill for the anti-rotation screw, the depth gauge, the star drive screwdriver shaft T25, the 4 Nm torque limiter attached to the large cannulated handle, the multifunction rod, which is used for both intraoperative compression and implant removal, and the large quick coupling handle. As previously demonstrated, the anti-rotation wire is inserted. The FNS has a 130-degree neck shaft angle, and it can be used in also more valgus and varus cases because of the angular stable fixation provided by a locking screw. The central guide wire is inserted using the 130-degree angled guide into the subchondral bone, ensuring that the tip of the wire is slightly inferior to the apex of the femoral head in the AP view and centered in the true lateral view. Clinically, it is confirmed that the guide wire is inserted into the subchondral bone with image intensification. In situations of a suboptimally positioned central wire, the correction guide can be used to adjust the position of the central wire so that it is centered in the femoral head and neck. In this demonstration, the wire shown in the bone model has been inserted too proximally and slightly off-center anteriorly. The correction requires the insertion of a new wire, 5 mm more distally, and at an angulation of 5 degrees more posteriorly. The FNS correction guide provides 3 adjustment possibilities: a correction of the entry point by 5 mm, a correction of the angle of 5 degrees, or a combination of both. This demonstration shows how to perform a correction of both. The correction guide is passed over the initial wire and rotated to achieve a more distal entry point. A new guide wire is passed through the 5-degree angle hole of the guide, and the guide wire is inserted to achieve a more posterior position. The first incorrectly positioned wire is removed. The correct angulation and position of the central guide wire are verified under image intensification in both the AP and true lateral planes. The direct measuring device is passed over the central guide wire. 5 mm must be subtracted from the length read from the direct measuring device, and the next shorter FNS construct size is chosen. In this demonstration, the length read from the direct measuring device is 92 mm. 5 mm are then subtracted from 92, equaling 87 mm, and rounded down to equal the reaming depth of 85 mm. The reamer is passed over the drill bit until it clicks into place and is set to the required length of the implant, which is 85 mm. The nut is passed over the drill bit, and the reamer is secured by threading the nut until hand tight. The assembly is passed over the central guide wire. The reamer is advanced down to the stop to ensure that the plate fits flush to the bone. Note that reaming includes all 3 levels of the reamer. Clinically, in the situation of dense bone, the use of continuous irrigation is recommended to prevent thermal necrosis. Image intensification is used to verify the reaming depth. Clinically, the migration of the guide wire must be controlled during reaming with regular image intensification. Note that if the guide wire is removed inadvertently, it must be centrally reinserted into the reamed hole. To reinsert the guide wire, the reamer is manually inserted into the reamed hole. The guide wire is passed through the cannulated drill bit and secured in the original position. The insert is slid into the insertion handle. The bolt with the selected construct size, 85 mm in this demonstration, is fully inserted into a one-hole plate. The assembled bolt and plate are slid into the slot of the insertion handle. The black screw is manually tightened to secure the implant. Observe that the implant must be correctly fixed to the insertion instrument and that the bolt is in the completely extended position. The assembly is passed over the central guide wire and inserted into the reamed hole with slight rotational movements. The cylinder can be used to manually tap the plate onto the bone if necessary. If additional tapping is required, a standard surgical hammer can be used to hammer directly onto the cylinder. Image intensification is taken to verify the insertion depth of the bolt and ensure that the plate is inserted down to the bone and aligned to the femoral shaft. The central guide wire is removed. The anti-rotation wire is kept in place to prevent loss of reduction and rotation of the head. The FNS features both an anti-rotation AR screw and a plate which accommodates a 5.0 mm locking screw. Shown is the plate positioning. Observe that the plate is inserted down to the bone and aligned to the axis of the femoral shaft. Note that it is possible to perform a secondary adjustment in order to align the plate to the femoral shaft by rotating the insertion handle. Clinically, the correct plate positioning is verified under image intensification in the true lateral view, and the locking screw is inserted, followed by the anti-rotation screw. This screw insertion sequence is strongly recommended. Firstly, the locking screw, followed by the anti-rotation screw. It is possible to reverse the screw insertion sequence and insert the anti-rotation screw first. However, this screw insertion sequence, first the anti-rotation screw, followed by the locking screw, does not allow secondary plate alignment adjustments in the situation that the plate is not aligned to the femoral shaft. Observe that if secondary adjustments are necessary, rotating the insertion handle results in a malrotation of the femoral head and damage to the vascular system, which increases the risk of vascular necrosis. It is therefore recommended to first insert the locking screw, followed by the AR screw, as is now demonstrated. Note that if the AR screw is inserted first, it is crucial that the plate is aligned to the femoral shaft prior to screw insertion. Under image intensification in the true lateral view, it is verified that the plate is parallel to the axis of the femur. If necessary, it can be confirmed by palpation. The implant and insertion instrument is rotated until it is laterally aligned, ensuring that the locking screw insertion is bicortical at the level of the femoral shaft. The protection sleeve for the locking screw is inserted into the most proximal hole of the insertion handle. Observe that the protection sleeve is in full contact with the handle when completely inserted. The 4.3 mm drill bit is inserted into the protection sleeve, and the bicortical screw hole is drilled, and the screw length is read directly off the drill bit. Alternatively, the depth gauge can be used to measure the bicortical screw hole. Note that the screw length should be chosen at least 4 mm longer than the measured depth of the hole. The locking screw is initially inserted under power, and final tightened with the 4 Nm torque limiter. An audible click is heard when the screw reaches the 4 Nm limit. The protection sleeve is removed by pressing the head of the sleeve together while pulling. The steps for an anti-rotation screw insertion will now be demonstrated. The fixation sleeve is passed over the back end of the drill bit. In this exercise, the fixation sleeve is set to 85 mm, which corresponds to the implant length and the length of the bolt. The assembly is inserted into the insert, and the hole is drilled until the fixation sleeve comes to a stop. The 85 mm anti-rotation screw is manually inserted with the 4 Nm torque limiter. An audible click is heard when the screw reaches the 4 Nm limit. Clinically, image intensification is taken to verify that the anti-rotation screw is fully inserted. The tip of the anti-rotation screw should be in a similar insertion depth when compared to the tip of the bolt. The notch of the anti-rotation screw should be at the same level as the notch of the plate barrel. The stabilizing wire is removed. Interfragmentary compression may be applied intraoperatively. The multifunction rod is inserted through the guide of the anti-rotation screw and fully inserted with manual clockwise turns. The black screw of the insert is manually turned counterclockwise to apply interfragmentary compression. Note that using additional tools on the black screw for compression may cause a pull-out of the implant. The multifunction rod is removed with counterclockwise turns. The screw of the insert is turned counterclockwise manually, and the insert is removed from the insertion handle. The insertion handle is removed from the plate by sliding it off the plate in a distal direction. Clinically, the implant size and positioning would be verified under image intensification before wound closure. To remove the FNS implant, the star drive screwdriver T25 without torque limiter is attached to the large handle. The assembly is used to remove the locking screw and the anti-rotation screw. The screwdriver is turned counterclockwise to initially loosen the locking screw. The screwdriver is then turned counterclockwise to loosen and remove the anti-rotation screw. The multifunction rod for insertion handle can also be used to remove the anti-rotation screw and the plate bolt construct. Observe that the head of the multifunction rod features 2 different thread diameters. The head of the multifunction rod is inserted into the anti-rotation screw with manual clockwise turns. The multifunction rod is firmly pulled and, if necessary, turned counterclockwise to fully remove the screw. The anti-rotation screw is removed from the multifunction rod. The multifunction rod is passed through the cylinder. The assembly is inserted into the proximal end of the plate, and the second, wider, more distal thread of the multifunction rod is turned clockwise to engage the plate bolt construct. The cylinder is manually tapped backwards to remove the bolt and the plate. You should now be able to identify the clinical indications, describe the surgical approach, outline the steps of the operative procedure for insertion of the FNS, explain the optional intraoperative fracture compression technique, describe the optional pre-collapsed technique, and outline the steps of the operative procedure for removal of the FNS. This technique is specifically recommended in the case of a patient anatomy which requires an implant length of 70 mm, as the shortest FNS implant length available is 75 mm. Additionally, the maximum sliding distance of the FNS can be reduced by approximately 5 mm, leading to a limitation of the maximum collapse from 20 mm to 15 mm. The pre-collapsed insertion technique can be used if the measured length of the central guide wire is less than 75 mm. The reaming depth is calculated and the bone is reamed as previously described. In the case where the implant length is measured at 70 mm, the pre-collapsed technique can be applied using a 75 mm implant. Prior to insertion, the black screw on the insert is loosened by 5 counterclockwise half turns to reduce the collapse distance from 20 mm to 15 mm. The shaft of the direct measuring device can be used to confirm a distance of at least 5 mm. The 5 mm longer bolt is inserted into the plate and attached to the insertion instruments as earlier described. In a case of a 90 mm implant where the amount of collapse needs to be reduced, a 5 mm longer implant is used. Prior to insertion, the black screw on the insert is loosened by 5 counterclockwise half turns, equaling a 5 mm reduction of the sliding distance, which decreases the collapse distance from 20 to 15 mm. Note that, if using the pre-collapsed technique, the drill length and anti-rotation screw size must correspond to the size of the bolt.